Zoll LifeVest is a proud sponsor of CardioNerds. Zoll has continuously improved LifeVest for over 20 years, leading to a median real-world wear time of 23.4 hours per day and an AI-enhanced algorithm that delivers zero median false alarms at 90 days. The newest LifeVest garment is lightweight, breathable, and preferred by patients for its comfort. Learn more at lifevestinnovation.com.
Hey CardioNerds, thanks for joining us for another amazing episode. This episode will explore the BPROAD trial with Dr. Keith Ferdinand, which compared intensive versus standard blood pressure targets in over 12,000 high-risk patients with type 2 diabetes. We'll dive into key findings, clinical nuances, and implications for cardiovascular prevention. This episode was planned in collaboration with the American College of Cardiology section of the Prevention of Cardiovascular Disease, with mentorship from the section chair, Dr. Eugenia Gianos. And with that, let's dive right in.
Hello, CardioNerds. This is Dan Ambinder, co-founder of CardioNerds, and I am here with CardioNerds Academy Fellow, Dr. Nidhi Patel. We are so grateful to have with us Dr. Keith Ferdinand. Dr. Ferdinand graduated from Harvard University College of Medicine, IM residency at LSU in New Orleans, and cardiology fellowship from LSU and Howard University College of Medicine. Throughout his career, he has been involved in national organizations concerned with public health, including the Association of Black Cardiologists, of which he was the former chair and presently chief science officer, and the American Society of Hypertension. He is a past chair of National Forum for Heart Disease and Stroke Prevention, and for years was a member of the NHLBI High Blood Pressure Education Program, which published the multiple JNC report guidelines on high blood pressure. He is Gerald S. Berenson Endowed Chair in Preventative Cardiology and Professor of Medicine at Tulane University. Truly, Dr. Ferdinand is most apt to discuss the invasive blood pressure control in patients with type 2 diabetes, aka the BPROAD trial, and its implications in our practice. So Nidhi, let's dive into a case to help elucidate the trial.
Thank you so much, Dan. Dr. Ferdinand, we're so excited for you to be here. We'll start off with a case. So we have a 65-year-old male with hypertension, type 2 diabetes complicated by microalbuminuria with a recent A1C of 8, and a smoking history who presents to the CardioNerds Prevention Clinic for follow-up. His BMI is 25.5 kilograms per meter squared, and he has been ruled out for sleep apnea 6 months ago with home sleep testing. He is taking amlodipine 5 milligrams daily, losartan 12.5 milligrams daily, metformin 750 milligrams twice a day, and dapagliflozin 5 milligrams daily. His blood pressure today in clinic is 145 over 90 millimeters of mercury. His home blood pressure reading ranges from systolic of 140 to 160 and diastolic of 85 to 100 millimeters of mercury. He reports compliance with all of his medications. Dr. Ferdinand, before BPROAD, what did we know about the management of hypertension in this patient?
Well, the BPROAD is interesting. It was a Chinese study, but I think that the results are universal. That in patients who have type 2 diabetes, their mean hemoglobin A1C was 7.6, so it was not tightly controlled, similar to this patient. Lowering the blood pressure to a goal of less than 130 has an improvement in composite cardiovascular outcomes, very similar to the SPRINT trial, which did not include persons with diabetes. So what it suggests is that what we thought would be true is true, and that is, regardless of whether or not a person has diabetes, especially in this particular case, the gentleman has an increased risk due to age, the presence of diabetes, microalbuminuria. We would expect that tighter control is better, lower is better. And I suspected that all along. There was some controversy because the ACCORD trial, which previously tried to prove that hypothesis, was negative. But it really never made good sense to me. And I think the BPROAD trial has now confirmed that in the presence of diabetes, controlling blood pressure to a goal of less than 130 gives benefit.
Well, thanks so much for that, Dr. Ferdinand. So let's dive further into the study. Now, investigators asked, does intensive treatment to control systolic blood pressure to less than 120 millimeters of mercury reduce the incidence of MACE in patients with type 2 diabetes? BPROAD was a multi-center study across 145 sites in China. The mean participant age was 64 and 45% of participants were women. The mean hemoglobin A1C was 7.6%, and on average, participants had diabetes for over 10 years. Now, elevated blood pressure was defined as a systolic blood pressure of greater than 140 millimeters of mercury without antihypertensive medications, or equal or greater to 130 millimeters of mercury, and taking at least one antihypertensive medication. Now, all patients also had at least one additional cardiovascular risk factor, including a history of prior MI or stroke greater than 3 months prior to study enrollment, subclinical CVD, current cigarette smoking, a BMI greater than 28 kilograms per meter, or reduced GFR like in the 30 to 59 range. Now, based on this criteria, our clinic patient would have qualified for the trial. Now, patients with secondary hypertension with a GFR less than 30, a history of CVD event less than 3 months prior, or symptomatic heart failure, or an LVEF less than 35% within the last 6 months prior were excluded. In terms of the intervention and control, participants were randomized to either standard or intensive treatment. The standard group targeted a systolic blood pressure of 140 millimeters of mercury, and the intensive group less than 120. As far as the outcomes, the primary outcome was MACE at 5 years, with a composite non-fatal stroke or MI, heart failure treatment or hospitalizations, or CV death. Nidhi, what did this trial end up telling us?
Sure, thanks, Dan. So both the standard and the intensive groups had similar baseline characteristics, including a baseline blood pressure of 140 over 76 millimeters of mercury. But it was amazing because after just 1 year of intervention, the median systolic blood pressure for the intensive versus the standard treatment group had actually a 20 millimeters of mercury difference, with 118 in the intensive group and 135 in the standard treatment group. Furthermore, at a median follow-up of 4.2 years, 393 participants in the intensive treatment group versus 492 in the standard treatment group experienced MACE. So this comes out to about a 21% lower relative risk of MACE in the intensive treatment group, which was actually much higher than I was expecting. The overall benefit in the trial was primarily due to a decreased risk of stroke events. They also looked at secondary outcomes in the trial, including hospitalizations, given these are older patients with diabetes, and they found that there were similar rates of hospitalization between the two treatment groups. However, the intensive treatment group was more likely to have symptomatic hypotension and hyperkalemia greater than 5.5, with 2.8% of the intensive treatment group versus 2% of the standard treatment group having these events.
Yeah, thank you so much, Nidhi. And so, Dr. Ferdinand, what do these results mean to you, and how do they inform what we do for our patients that we see in the CardioNerds clinic?
So first, let's look at the present U.S. guideline. The ACC-AHA Multi-Society Guideline was actually published in 2017. So we're far away from that time period at the present time. Nevertheless, this suggests what many hypertension specialists and preventative cardiologists have been saying, and that is lower is better. The reason I use the cut point of 130 because that is what the present guidelines suggest for all patients, including those with diabetes. Now, some of you may recognize the controversy with the ACCORD study, which tried to reproduce what we saw in SPRINT in persons with diabetes and was a negative study for the improvement in overall cardiovascular events and cardiovascular death. But there are some things there in the ACCORD that we should recognize. One is the sample size was much smaller, 4,700 patients, and it had a design in which patients were put into various aliquots of intensive glucose control along with intensive blood pressure control, which then cuts down the sample size and gives the maybe unintended consequence of muddying the waters in terms of the blood pressure effect. This particular study had persons who had diabetes. It confirmed that in those persons who have diabetes, achieving a blood pressure close to 120 or less, with a goal of less than 130, as suggested by the 2017 ACC-AHA Multi-Society Guidelines, was correct. It was the right call to make, and that is intensive blood pressure reduction in persons with diabetes. In this particular case, I think you could say poorly controlled or uncontrolled diabetes gives benefit. Another thing that I like to do when you look at any study is look at the subgroup analysis. It's going to be hypothesis generating, but it gives us a lot of comfort whether or not these results can be used more widely. Although it was a Chinese population, they did cut the sample sizes into less than 65 or greater than equal to 65, and the effect was the same with no p-value for interaction. They even did a cut point of 80 years of age or greater, and the confidence intervals are wide because it was only about 200 persons out of a large trial of 12,000 or more. So the sample size there, again, being small, does not give you any final confirmation, but it did seem to have the same trend towards benefit, even those very old persons. One good thing about this trial, about 45% were female. We know that even in U.S. trials, we under-enroll women in the trials. And here again, the trend was the same with no interaction, whether you were male or female, no interaction whether there was previous cardiovascular disease or not, and no interaction whether the person had previous chronic kidney disease. So it's pretty confirmatory for me that the 2017 ACCHA Multi-Society guideline was correct, that in high-risk patients, including those with diabetes, getting that blood pressure less than 130, and who knows, get maybe down to 120 gives a benefit in MACE.
Thank you so much, Dr. Ferdinand. I had a question for you. Our listeners may be wondering if they can apply the findings of this study to their patients. I know that you mentioned that this was an only Chinese population in the study. Do you feel like these results are applicable to the general public, or are there patients here where you feel like the results would not apply?
Yes, I do. I think it could be widely applied. In fact, we know in the Chinese population, there may be even a greater tendency to have stroke-related cardiovascular events with elevated blood pressure. And we also know that regions of residency may have some impact, but boy, the sample size of this study was so huge, the p-value was so strong that I would really hesitate to suggest that somehow an American population or a European population would not get the same benefit. And I'm convinced that you have a person who is high risk, in this particular case, diabetes with an A1C greater than 7, and they have age, the average age being in the 60s, those persons will benefit from intensive blood pressure reduction. I think that's proof positive. You know, we had an earlier signal, a trial called ESPRIT, which was published in Lancet in the summer of 2024. It also was a Chinese study, also a large sample size, several thousand, and 39% of the ESPRIT trial had diabetes. They showed the same benefit of getting blood pressure to down close to 120. They actually achieved about 119, gave a benefit in MACE. So I'm not really in the point right now where there's much debate. We'll see in the future if American guidelines reflect this, but I would suspect that we're going to stay with the idea of less than 130, and if it can be achieved safely without undue side effects or complications, perhaps even less than 120 in some of these high-risk patients.
Thank you so much, Dr. Ferdinand. I'm actually in my primary care clinic tomorrow, and a lot of my patients have uncontrolled hypertension and diabetes. So I'm excited to take back some of these learnings already into clinic and be maybe even more aggressive with blood pressure and control in my patient population.
When you go into your clinic, let's not move too far from the case. The case was a person 65, so the age was similar to what we see in BPROAD. A1C was 8, very similar. And the blood pressure was stage 2. Now, we know with stage 2 hypertension, defined as the systolic or 140, it takes 2 or more medicines to get these type of intense blood pressure reductions. In the case that you presented, the amlodipine dose was 5, which is really to a large extent a starting dose. But even more distressing, the losartan dose of 12.5 is at least 1/2 of the conventional starting dose. Losartan is a prodrug and has to be activated in the body. Some people don't respond as good as others. But if you look at the ARBs, it's a pretty poorly effective ARB for blood pressure reduction. So 12.5, boy, I'd like to see this guy on 50 or maybe even 100 to get a better blood pressure reduction. And we know that in patients who have this type of a phenotype, He had overweight status, not frank obesity, but he did have stage 2 hypertension. You're probably going to have to get benefit of a thiazide type or thiazide-like diuretic. The reason I use that nomenclature, hydrochlorothiazide is okay, but if you look at the really big outcome studies, such as ALLHAT, chlorothalidone might be a good choice for this particular patient. There's another one, indapamide. It's used in the European studies like ASCOT, and it also showed benefit. So he's going to need more medications, perhaps in combination, in order to improve adherence, because we know the number of pills tends to complicate therapy. And he is going to need, of course, therapeutic lifestyle changes, a DASH-like diet, low in sodium, high in fresh fruits, vegetables, legumes, lean sources of protein. That's going to take a team. It's not going to be that magic doctor visit 2 to 3 times a year for 15 minutes, 99214. It's not going to cut it. You're going to have this guy have a follow-up with diabetes educator, other advanced practitioners, nurse practitioner, advanced practice nurses who are going to see. And there's a movement now in patients who have uncontrolled hypertension or a new diagnosis, out of office, whole blood pressure monitoring. So what I usually do is send these patients to validatebp.org. It's a nonprofit site sponsored by the AMA, and you can see the various blood pressure tools that are there, and the patient can get a valid blood pressure monitor so that he, in this particular case, he, or if it was a woman, she, could monitor their blood pressures at home.
Thank you so much, Dr. Ferdinand. You have so many pearls to share. I appreciate how clinically oriented all of your pearls were. We'll go ahead and share the link to the validatebp.org in the script below so our listeners can check it out. I had another question for you, Dr. Ferdinand. Can we ask you to look into the future and anticipate what future trials may focus on? And how do you think we can standardize the application of these findings into clinical practice?
Well, we never know what the future holds. We're simply human beings, and it's hard to predict tomorrow. But I was convinced early on that lowering blood pressure is one of the best things you could do for your patients. If you look across the conventional cardiovascular risk factors, hypertension is the most prevalent and potent of those risk factors, and globally, millions of lives are lost by hypertension. Another thing that we're going to see in the future is that many patients that we're now pigeonholing as Alzheimer's disease actually have small vessel disease from uncontrolled hypertension. And we need more studies to confirm this. The Sprint had a MIND study, MIND study, that suggested that it did affect in a positive manner cognitive function. So we need to really try to drill down on that. But I suspect we are going to find that controlling blood pressure not only reduces MACE, but cognitive dysfunction. And many of these patients who we're saying has Alzheimer's actually has the effects of small vessel disease from poorly controlled hypertension. So that's what I would like to see in the future. Now, we know there are a lot of medications on our rising. There's some really interesting things. There's zilebesiran, which is a RNA silencer for angiotensinogen, the first step in the renin-angiotensin system. There's some novel aldosterone synthase inhibitors like baxdrostat and lorundrostat, which turn off aldosterone itself. We know the non-steroidal aldosterone antagonist on the horizon. And we have some drugs which not really now approved for treating hypertension, but have a blood pressure lowering effect that we need to hone down on some more. For instance, he's on dapagliflozin, again, at I think a subtherapeutic dose at 5 milligrams. Most of the outcomes are with 10 milligrams. I did a study with 148 Black patients, and we got a robust 24-hour ambulatory blood pressure reduction after placebo subtraction of 8.5 millimeters of mercury, with the addition of another SGLT2 inhibitor to their blood pressure regimen. So I would maximize the dapagliflozin in this patient and suspect that that may give some benefit. And we know that in patients with HFpEF, there's a benefit in exercise tolerance and symptoms with GLP-1 receptor agonists, and also the GLP-1 receptor agonists along with GIP. So I would suspect not necessarily to get this guy on a lot of expensive medicines that he may not have access to, but in the future, we're going to drill down on the benefit of weight loss with the incretins and their effect on blood pressure. So that's some of the things in the horizon. But boy, I have enough information right now to say that you should always treat patients who are high risk to a goal of less than 130. And if you can achieve it safely without undue complications, 120. One more comment. Sometimes what we see in observational studies is not reproduced in interventional studies. So if you look at systolic blood pressure, which is the main phenotype that was measured in BPROAD, we know it starts at about 115, where you start to see an increase in cardiovascular disease and overall mortality. So I'm actually not that surprised that in high-risk patients, if you can demonstrate, which they have demonstrated in this large randomized trial, if you can get them down to closer to 120 or less, you may even have benefit beyond the 130, which is in the present guideline.
Thank you so much, Dr. Ferdinand. It was nice looking into the crystal ball of blood pressure medications. It seems like there's a lot of medications on the horizon and already a lot that we have in our toolkit. And I like that you emphasize that we have to think about cost for patients as well as potentially combination pills to reduce the burden of polypharmacy, especially in some of these older patients as well. I had one last question for you, Dr. Ferdinand. Can you briefly share, based on your expertise, where does renal denervation therapy stand amidst of this new research coming in about hypertension management?
Wow, that's a great question. As I mentioned, there are new pharmacotherapeutic agents that are being examined now for the treatment of hypertension, especially in high-risk patients. But we already have 125 blood pressure-lowering medications. So our first charge will be to implement the use of what we know works. And these are often fairly low-cost generics in combination. And what combination is that? Long-acting calcium channel blocker. I like amlodipine. This patient was on amlodipine, although 5 milligrams may not be the maximum tolerated dose. He may do better with 10 milligrams. A RAS blocking agent, a modulating agent, that would be an ACE or an ARB. And though we as cardiologists love ACE inhibitors because of the benefit we've seen with HFrEF, ARBs for blood pressure effect are just as good and probably better tolerated. You don't get the 10 to 12% cough because you're not stimulating bradykinin. And especially in African Americans, you don't get the angioedema. Although it's been rarely seen with an ARB, it's really uncommon. The third group is a diuretic. What diuretic? Well, I like thiazide type or thiazide-like, and that's going to be chlorothalidone or indapamide. Now, you can use hydrochlorothiazide, and I think most of you heard of the veteran study that suggested that hydrochlorothiazide was equal to chlorothalidone in its effect. But if you look within that study, the dose of chlorothalidone they used was 12.5. And in a subgroup analysis of patients who had already had a stroke or myocardial infarction, there was a statistically and clinically significant benefit with chlorothalidone. So I would probably like to see this guy on chlorothalidone and indapamide, maybe even a combination of an ARB and a long-acting calcium block in one pill in order to decrease the pharmacotherapy. I didn't answer your question, and I know I didn't. We're going to get there. What about renal nerve denervation? Well, the FDA has approved two approaches. One is using ultrasound and the other radio frequency. And those devices do seem to be beneficial in patients who have difficult to treat hypertension. Now, the blood pressure effect is not as profound as you would think. In some of the trials, it's been 5 to 6 millimeters of mercury. Certainly nothing that is going to be confirmatory in all of these patients that we're going to get them less to the more robust goal of less than 130. But we really don't know who responds better than others. And some patients will get that type of tight blood pressure control. It's not going to remove the need for pharmacotherapy, but it may simplify pharmacotherapy. So versus 3 or 4 medicines, maybe now it's a combination pill with just 2 medications and renal nerve denervation that might get you there.
Well, thank you so much for that, Dr. Ferdinand, your approach to hypertension and insightful walkthrough of the BPROAD trial. This study really highlights the importance of intensive blood pressure control in patients with type 2 diabetes, especially in reducing stroke risk. which reminds us to carefully weigh the potential for adverse effects like hypotension and hyperkalemia. Nidhi, it's always a privilege working with you. Your insightful case framing made this study engaging and easily digestible for myself and our listeners. And of course, a heartfelt thank you to both of you for your invaluable contributions to this discussion as we strive to advance cardiovascular care together, particularly with regards to our patients with hypertension and diabetes. So thank you both for your time tonight.
It was my pleasure. And I like to leave with, I call a SOCO, S-O-C-O, single overriding communication objective. And hopefully we've met that. That blood pressure is the most prevalent and potent cardiovascular risk factor, that we're not doing a good job, and that in high-risk patients, including those with diabetes based on the BPROAD study, targeting a blood pressure less than 130, in this case, achieving a blood pressure of 120 or less, reduces MACE.
Hey everyone, do you dread doing your notes every day? Do you feel like you can never get ahead of charting? If you're shaking your head yes, then keep on listening, because Freed AI is a medical scribe on a mission to free clinicians everywhere. Freed AI listens, transcribes, and writes medical documentation for you. So just imagine leaving your office at the same time as your last patient. Now, wouldn't that be delightful? Freed AI is HIPAA compliant, secure, and takes less than 30 seconds to learn. Team, artificial intelligence cannot replace you, but it can do the administrative work that will allow you to spend more quality time with your patients and enhance your personal work-life harmony. So get back to doing what you love, helping your patients, and let Freed AI do the rest. Check out www.getfreed.ai to learn more.